We'll be starting our meeting in a minute. We'll just wait for 30 seconds to 1 minute. Good evening, everyone, and a very warm welcome to today's webinar brought to you by Institute of Public Health, College of Medicine and Health Science, United Arab Emirates University. My name is Alina Hassan, and I'm delighted to serve as the moderator for today's session. On behalf of Institute of Public Health, I would like to thank you all for joining us this important and timely webinar entitled UAE Genome Oasis and Biobank. At the Institute of Public Health, we remain committed to creating platforms for meaningful knowledge exchange, interdisciplinary dialogue, professional development through scientific webinar series. This webinar is part of the global This is Public Health initiative, which aims to highlight pressing public health issues and inspire action through education, research, and collaboration. We are also proud our affiliation and collaboration including ASPER. Before we begin, I would like to share a few housekeeping points. First, we encourage you and engage actively during the session. If you have any questions for the speaker, please write them in the Q&A session and which will be addressed in the discussion period. Second, the webinar is being recorded and the recording will be available through the Institute of Public Health channels for those who to revisit and share them. It is now my great pleasure to introduce today's distinguished speaker, Dr. Mohamed Alameri, Division Director of Genome and Biobank at the Department of Health, Public Abu Dhabi, UAE, as our distinguished speaker for this webinar. In addition, he also served as the genomic advisor for the Emirates Genome Council. Dr. Al-Ameri brings an extensive academic and professional expertise in genomics, personalized medicine, molecular diagnostic, and biobank development. He holds a PhD in epigenetics of pediatrics acute myeloid leukemia diagnosis, a master's degree with a distinction in cell and gene therapy from University College London, and a bachelor's degree with honors in genetic from the University of Western Ontario, Canada. He previously served as a teaching fellow in the MSc program in gene cell therapy and personalized medicine and novel therapies at the University College London, and worked as a medical laboratory technician in the molecular diagnostic laboratory in Sheikh Khalifa Medical City. He is also a member of the British Society of Genetic Medicine and Cancer Genetics. During this webinar, Dr. Al-Ameri will share valuable insights into the genomic biobanking and their role in advancing precision medicine and healthcare innovation. Dr. Mohammed, thank you for joining us today. This floor is all yours.
Thank you very much, Alina. Just let me share my screen and I can start. Perfect. Can you see my screen?
Yes, doctor.
Yes, doctor.
Perfect. Thank you very much, everyone, for attending. And I heard there's some good news that some of you will not be coming to university on Friday. So that's I guess that's a good thing. So I'll just give you a brief about the Emirati Genome Program. Where are we so far, and what is the Abu Dhabi Biobank, and why do we need a biobank in the UAE? So to start off, since the initiation of the Human Genome Project, which was back in 1990, and I'm sure a lot of you were not born that time, a lot of countries have wanted to have their own genome program. So we've sequenced the first human genome back in 2003 in the Human Genome Project, and then since then, a lot of countries have started sequencing their own population. So we've seen a lot of programs such as the UK Biobank that have sequenced more than 500,000 actually now, and the American All of Us population cohort program as well. They've sequenced around 400,000 as well, and then also other countries such as Singapore have started with their SG 10K, and then now they're pushing for SG 100,000, so 100K. And there are also countries that are, let's say, close to UAE, such as Qatar, that started in the 2015, and they've sequenced around, if I'm not mistaken, around 40,000 genomes. And then the Saudi program, the SGP, started in 2013. They stopped for a bit, but now they're back. So they sequenced around 69,000 genomes. And then we have the Emirati Genome Program, which started back in 2021. So initially it started in 2019, then stopped and because of COVID, and then initiated again in 2021. So since then, we've sequenced around 900,000 genomes. So that number is huge. Not many people would let's say comprehend it, but in the genome world, having a whole genome sequencing 900,000 in a population is a big number, especially if that is, let's say, 900,000 of the same nationality. And as well as the, let's say, the Arab population and the West Asian population are usually what we call an underrepresented population. So these are, let's say, we are among the population that have not been researched, let's say, as big as the Western population. So we can see that there's a clear need of having a population genome program, not only in the UAE but in the whole region, and that's why that puts the UAE, let's say, in the forefront of the underrepresented population, and then that makes us the biggest database for the underrepresented populations, and hopefully this will lead to novel discoveries and novel therapies that are specific to the to our population and the region. So the first thing that we wanted to do since we started the program was actually building our reference, the Emirati reference genome. So for those who don't know what a reference genome is used for, usually when we sequence a genome, we usually align it to a genome. We align it to a genome that we know, so that we make sure that it's kind of like our genome is structured. So what people, scientists are using at the moment is something that we call SG 38, or also pangenome, the global van genome. But the issue that we're facing is that there are a lot of gaps in these genomes when we try to align our genomes, and that leads to a lot of let's say a lot of sequencing that fall a lot of sequences that fall within the cracks. So we're not able to detect, and this leads to let's say us missing some diseases, some variants that might be prevalent within our population. So we started aligning our multi-genome platform with scientists from different universities, but mainly the Khalifa University and the team from 42. And we've done that, and we've discovered that there's a lot, around 12% of our genome is not really, let's say, represented in let's say global genome or global databases, and this makes our genome unique. So we now know the uniqueness of our genome. We used to hypothesize it, but now we actually know it. We know that there are around 575 genetic variants that we haven't seen in any other place, in any other database. So this makes it exciting for us to dig deeper in our genome. And then we built something called pangenome, basically making sure that we we sequence the whole genome, even the missing places. There are some missing places that we try to make sure that we cover within the genome. And then this led to something called the telomere to telomere, basically making sure that we also sequence the ends and the centromeres, so in the middle of the genome. And these are usually the most difficult parts to sequence. And this um, this kind of like gives us the most accurate full sequence, and also helps us with a lot of the, let's say, aging studies, especially that a lot of the aging studies are focusing on the telomere part. So we've done that, and then we were like, okay, now what? What can we do with it? In Abu Dhabi, we're focusing a lot on the implementation. So how can we use the Emirati Genome Program in implementing, let's say, programs that will benefit patients? So we started with sorry. Before that, we wanted to be, so we know that we are one of the fastest growing countries when it comes to genomics. And we do acknowledge that, but we need to make sure that we're also the fastest, let's say, the fastest growing countries in upskilling our physicians, and making sure that we have new genetic counselors and new clinical geneticists every year, so that the we can cope with the new programs that are initiated within our let's say our hospitals or our healthcare ecosystem. So we addressed the growing gap of genetics in healthcare, and we started multiple programs that were to upskill our physicians and for our pharmacists and also our allied help. So we started programs such as the Clinical Genomic Medicine and Genetic Counseling Program with Mass General Brigham and Harvard and Khalifa University, where we have upskilled 100 Emirati physicians from different emirates within the UAE. Also, we started another program with UAU, والدكتورة فاطمة الجسمي and دكتورة منى الصفار, to upskill our physicians, especially our family physicians, to understand and interpret, let's say, genetic data when it comes to premarital genetic testing. And this is the genetic screening, premarital genetic screening that now you see implemented within the UAE, and also mandated, so everyone has to go through it. Sorry if I kind of messed up any marriages, or the team did, but this is very crucial to our population, and I'll go over it and in the next few slides. We also had another upskilling program for pharmacogenomics. So we've made sure that we have clinical pharmacists upskilled, as well as physicians upskilled. So we make sure that they let's say they fully utilize the benefit of our pharmacogenomics report that is now implemented within our healthcare system. Last but not least, is the newborn genetic screening program, and this is, let's say, the most recent program that we have launched in Abu Dhabi. It's currently optional. I'm gonna go over it in a minute, but we needed to make sure that our physicians, obs and gynae, are, let's say, upskilled to understand why are we doing this program, and what is it that we're screening for, and how can we also, for the pediatrician, how can they also interpret the data and consult the patients. So far we've upskilled around 100 mass physicians. I mentioned 194 physicians upskilled for premarital genetic screening and counting, actually. So we haven't stopped. We've also upskilled 80 pharmacists and also counting, and 16 physicians trained for newborn genetic, and another 25 physicians, making sure that every maternal hospital within Abu Dhabi had the capability of having newborn genetic screening program. So one of the earliest programs that we started is the premarital genetic screening, and this is what I was talking about. So the reason why we started this program is because the UAE is ranked 6th globally in prevalence of genetic and partially genetic birth defects. So when we were let's say addressing these genetic mutations, we saw that most of them are caused by what we call autosomal recessive diseases. So these are, let's say, both couples need to be carrying an autosomal recessive gene or a mutation that would have a 25% chance of causing let's say an unhealthy baby or a baby with a genetic defect. So and the only reason why we, well, not the only reason, but the main reason why we get, let's say, we still get these kind of diseases is because of consanguinity. So we know that from studies that there's around 30% consanguinity rate in Abu Dhabi. And when we say consanguinity, we mean first cousins, mostly first and second cousins. And usually what happens is that these diseases um, are usually, let's say, stays within the lineage of that family, and that's why it's causing these diseases. And most of these families actually have seen, let's say, a member of their family that has this certain disease. So we started with the 570 genes, and as I mentioned, these are autosomal recessive genes for 840 conditions. So we wanted to make sure that what we're doing is, let's say, correct. So we have an evidence-based approach that of a program that has started before even we started the prenatal genetic screening, which is the thalassemia program. So we saw that there was a 50% reduction in thalassemia cases just by informing or testing for thalassemia during let's say during marriage or during let's say premarital programs. So we thought that, okay, if we do the same thing with with more genes, then we're hoping that we're gonna have a much better reduction. And we've done a study with Khalifa University where we saw that uh, you can clearly see that the number of, let's say there, it says the region of free homozygosity. I'm not sure if you can see my mouse, but the regions of homozygosity basically is saying that the level of having or the chances of having, let's say, a child with an autosomal recessive disease gets lower and lower when the couples are not related. And so that's the main idea, and we need to make sure that we need to break at least one generation of this disease so that we can have multiple generations afterwards with hopefully with no diseases. So there are 22 clinics across the Emirates of Abu Dhabi that runs this program, and this is mandated throughout the country. And and if you're Emirati and getting married anywhere in the country, you'll have to do this test. So. And so we're focusing mostly and focusing most of our awareness sessions on higher frequency homozygous regions, making sure that they are, let's say, well educated and know exactly let's say know the consequences of the consanguineous marriages. We don't stop any marriages. I just need to clear that out. We just give them we give them full autonomy of choosing whether they want to go ahead with their marriage or not. And also we give them some solutions such as IVF that the country would pay for. The other program that kind of like adds to it is the newborn genetic screening program. So there are multiple international programs that have started a couple of years ago. So we have the Guardian program in New York and the States, and we have the Generation Study program in the UK. And now, I'm not sure if you've heard, the States are there's a big multi-state program in the States called Beacons that is doing something similar to this. So the focus here in the newborn genetic screening is it's not similar to, let's say, the prenatal genetic screening. In the newborn genetic screening, we're focusing mostly on, let's say, actionable genes. So these are genes that if I find, let's say, a baby with a positive condition, then I have a treatment for, I have an intervention for. So the idea here is not to cause anxiety to the parents, but making sure that if they have a baby with a condition, we know how to treat them and basically making sure that they have a good quality of life. So So we're focusing here mostly on what we call likely pathogenic and pathogenic variants. So making sure that if you have this, then most likely, if the baby has this variant, most likely they will develop a disease, and we need to intervene as soon as possible, making sure that they have a much better quality of life later on. So so this is now an optional phase. Hopefully, you'll get to see more of it in Abu Dhabi, and hopefully you get to see it expanded to all other Emirates. And once we have, let's say, more data, we'll be happy to share them with you. Then we have a program. So this is one of the first programs that we actually initiated due to the, let's say, the seriousness of the problem here with breast cancer, because breast cancer is one of the, let's say, main causes main more cause of mortality among cancers. So we wanted to see if because we've seen that a lot of our, let's say, population develop cancer younger, let's say a decade younger than other populations, especially Western world populations. So we wanted to start a germline program that will, let's say, make us able to identify patients with predispositions, such as BRCA2, RAD50, let's say. So we've done this study, and we initiated this program actually, where if we diagnose a patient with cancer, let's say especially breast and ovarian cancer, then we cascade screen the whole family, making sure that we are screening these family members and more often to make sure that we catch it very early, and this leads to let's say a better survival rate to that patient. So we had the 47 gene panel. We've done this with CCD, so Cleveland Clinic Abu Dhabi. We did the family cascade testing. We have a gene-based management strategies, and we identify those individuals at high risk for cancer to push them into the clinical pathway. So I know that I mentioned that let's say we catch it a decade younger than, let's say we have patients a decade younger than Western population, but this could also mean that because we have much better screening programs, such as this program, that let us detect those cancers before they appear, and this helps us later on with the follow-ups, and also helps us all with the survival rate for those patients. The other program that we started is the cardiovascular flagship program, and this was done with CC with the SSMC. So we've started. So we know that the number one cause of death in the UAE is CVDs, and there's a 40% mortality rate. So we wanted to make sure that we have, let's say, a very comprehensive panel that covers a lot of those CVDs, and making sure that similar to the cancer, that if we catch or if we diagnose a patient with any of those diseases, we cascade screen the whole family. So we started that program, and this led us to enhance diagnosis for cardiovascular diseases. We also have, similar to the cancer, gene-based management strategies to improve the outcomes. And again, as I mentioned, that we have family cascading the patients, and this led to reduction in mortality rate. But hopefully, we'll be able to put a number to it now with many other programs that we're starting also for CVD, that will help us put a number on the reduction in mortality rate, and we actually physically see a reduction in the mortality rate caused by CVDs. Another program that we've initiated in the UAE is the pharmacogenomics program. So we made sure that in every Malati within Abu Dhabi, that is, let's say, a TAFA holder, would have a pharmacogenomics report within their file. So we've done a study like a proof of concept with the DSCC, and we saw that 47% of the participants had an actionable pharmacogenomics gene drug interaction, and this led us to basically push for this program, where we still want to put a number on the cost benefit analysis of this program, but we can clearly see that, let's say, this will lead to a better, let's say, better treatment, better personalized treatment for our patients, specifically in certain areas such as neurology and CBDs. So hopefully, soon we'll be able again to put a number on this, making sure that we know how much we saved and not only money, but in life as well, making sure that we have less side effects to all the treatments within the pharmacogenomics report. Last but not least, I know I promised you, Dr. Azhar, to go for 14 minutes, but it seems like I'm gonna end it here. I'll leave more of the time to the questions. The last program, let's say one of the biggest programs that we've launched in Abu Dhabi is the Abu Dhabi Biobank. So this is a physical building that you can visit in Abu Dhabi, and I'm sure a lot of you have done so. So the idea here is that we need to make sure that we have the samples. We have, so not only, let's say, the genetic data, but we also have the samples themselves, whether there were pan-human samples, so tumor samples, or let's say core blood samples that can be used for treatment later on, and research within Abu Dhabi. So we collect this data, and this will give us, let's say, um, a much better idea and it will also enable us to do a lot of research that will make us study our own, let's say, diseases such as especially actually cancer, so our cancer tumors. So we know that our cancer tumors are different than, let's say, other populations. We need to make sure, we need to know how is it different from other populations, especially now that we have the germline, so the Emirati Genome Program, which is the germline program. And also we have the phenotypic data from Malafi. So we have all the clinical data for those patients as well. So we need to make sure that we also have what we call somatic data. So for these kind of let's say tumors, we need to understand how do they operate, what makes them unique, how can we, let's say, tailor personalized care based on those tumors and their markers, and how can we use what we studied there for prevention, and how can we make sure that we develop, let's say, novel drugs that will target tumors that are specific to our populations. And last but not least is how can we have a system integration, putting everything together. And this is something that we are trying to put within let's say, a federated trusted research environment at the moment, is that we want to put everything when it comes to genomics, when it comes to clinical data, when it comes to the samples from the biobank, and when it comes to wearables, putting everything together and linking everything together gives us a much better idea, or let's say a much better comprehensive view on our on Emirati patients, and also our Emirati, let's say, genome, and in a much more holistic way. So hopefully this will lead to more research and novel discoveries, and also looking at it from a regulator, much better policies and much more agile policies that will help us with clinical trials, um, with novel drug discoveries, and also attracting biotechs to the UAE, making sure that the UAE will become the center of genomics, not only the region, but also inshallah globally. So with that, thank you very much. I really hope that you enjoyed this presentation. I know it was brief, but hopefully next time I will come to you with results that will show the effectiveness of the Marathi genome program, and all the data that's coming with it. So if you have any questions later on, if you're let's say If you don't want to ask any questions here, you can always email us at genome@doh.gov.ae, and we'd be happy to answer all your questions. Thank you very much.
Thank you so much, Doctor, for your insightful presentation. Now it's time for the Q&A session, and I request all the participants to put on your questions in the Q&A and we could discuss it. So, Doctor, we have received excellent number of questions, excellent questions, and I hope you are ready to answer those. So, our very first question is,
Sure.
were the samples collected only from healthy individuals or were they categorized into deceased based on the subclasses?
So I know there are programs such as the UK Biobank where they've let's say segregated first the patients and then collected the samples. Where in the UAE we decided to sequence everyone, and then because we have, let's say, what we call Malafi, which is our exchange health record, we can segregate later on. So that's what we opted in for. So sequence everyone, regardless if they're healthy or not, and then we can segregate them using Malafi later on.
Thank you, Doctor. Another question from audience is, could you please elaborate on newborn screening programs for spinal muscular atrophy, the SMA?
So, sorry, can you hear me? I'm sorry, it keeps cutting.
Yes, yes,
Can you hear
Doctor,
me?
yes. Yes.
Okay, perfect. Okay, so for SMA is one of the, let's say, um, um, most confusing disease, let's say, because the thing is, we don't only have it in the newborn genetic screening, but we also have it within our prenatal genetic screening because it's an autosomal recessive disease. So we have the SMN1 gene within both. The reason why we have it in both is because we want to stop it from going to the next generation, even though there's a gene therapy for it. But the gene therapy is very, very, very expensive. So we got millions. So what happens is that we try to stop it at the premarital level, but if we catch it during the newborn genetic screening, we make sure that this patient gets the new gene therapy as soon as possible.
So moving on to the next question, since we live in the era of AI, we have a question related to AI. How can artificial intelligence support genomic research?
Well, AI is it's not really
AI is
supporting
ruling the
as
world.
in. Exactly. So now it's AI is taking over. A lot of the things that we're doing now, let's say in a way manually. I'm not gonna say manually, but in a way that let's say from sequencing to tertiary analysis, this soon will be AI based. So we're not gonna need to do it or code for it to get there. So hopefully soon. So AI kind of delved into the genomics, but when it comes to drug discovery, mostly, but still hasn't gotten to, let's say, population screening programs yet. But we can see that happening within the next few months. I'm not even going to say years. Within the next few months. So we can see it, let's say, ruling the genomic world. And hopefully, within our federated trusted digital environment, we're going to see more AI implemented there. This will gives us, let's say, an idea and much better, um, let's say, much better idea or much better view of the Emirati population when it comes to diseases and other wellness programs.
Shall we move to the next question, Doctor?
Yeah.
Uh, It has been asked that what has been the biggest challenge in expanding premarital screening program from just two genetic diseases to cover all the 840 conditions other than the cost issue?
Uh, Surprisingly, cost was not the issue. The issue
Yeah.
was because
Yeah, it was asked other than
um,
the cost issue.
yeah. So the main issue was we tend to forget as scientists that this is a cultural program. It touches a lot of the culture and tradition, especially when it comes to marriage. So that's one of the things that we kind of like I'm not gonna say that we forgot about. It's just something that we didn't think that it would matter that much, and then we were shocked on how much let's say tradition played a huge role in this, and this kind of like got us to a point where we thought, okay, we need to increase the awareness, especially when I mentioned like there are certain regions that we needed to increase more awareness there to basically educate them in a way that we're not touching tradition, we're not touching culture. If anything, we respect tradition and culture, but we need to make sure that they have a healthy baby in the end or a healthy newborn. So that's the main idea. So one of the good things that we've seen, to be honest, and something that touched me personally is that now, at the beginning, we were seeing that let's say the younger generation are the ones that are pushing for the prenatal genetic screening. But now we're seeing more of the older generation pushing for it. And I remember one of my friends actually told me that he was proposing to a girl, and then her dad was like, "Go do the genetic testing first, and then if you come back negative, then we'll talk." So that actually kind of like makes me happy that the awareness have reached those let's say the older generation, and now they're making sure that let's say their children would have healthy newborns.
I think the question I'm going to ask next is something that everybody is a bit curious about. What was that strategy you have been using that encourage participants to donate samples to the biobank? That
What was
effective
what
strategy. What was
the
the effective
strategy
strategy? Yeah,
the
that encouraged
strategy
people
for
to
the
donate.
genome uh, so so for the genome program or for the
The
biobank
biobank.
biobank?
Yeah, yeah.
Okay. So for the biobank, it's mostly because the thing. So usually what happens in hospitals, there's when it comes to, especially when it comes to cancer tumors, let's say, we usually actually consent the patients for research, because this will help not only them but also future patients. So it really wasn't that difficult. What was difficult is let's say the cord blood samples, let's say, in a way. So cord blood samples, we needed to make sure that we educate the let's say the mother, especially because that's where we get the cord blood samples from, that let's say this cord blood would help someone else. So especially when it comes to treatment, so we can use those for treatment. So with that awareness session and the amazing help from the Abu Dhabi Biobank team, we were able to collect a lot of those samples, whether it was cord blood sample or pan-human samples. So there's an ongoing like outreach program, people that are making sure that they increase the awareness of patients and participants.
I've noticed that there were a lot of researchers in our Q&A asking, and everyone is curious to know that if there is any way they could access these data. We have been
Uh,
getting data that who this data belong to, how can they access it, is there any way to access the data? So,
To be honest, it's really surprising that we spent like 10 minutes before anyone asking this question. Because usually this is the first question that I get asked. So hopefully, as I mentioned, we're building something called a federated trusted research environment. Hopefully, once we have that ready, we'll give access to researchers. So all the patients or all the participants and volunteers have consented that their data can be researched on, and we also have the molecular data, the phenotypic data as well. So hopefully once we have this trusted research environment up and running, then similar to, let's say, the UK Biobank and all of us, researchers will be able to access the trusted research environment, build their own cohorts, research, and of course, after having an IRB board approval, so like ethical approvals from their universities and also from the Department of Health in Abu Dhabi or in Dubai. If they're in Dubai, they get Dubai's IRB and so on.
So, UAE Professor Dr. Balaz Adam is asking, do you continuously follow up the medical developments of the biobank participants?
We do not actually. We do not. Um, there are multiple reasons why. But what we do is mostly like we just pinpoint the time on when was this collected. So we just like we will tell, let's say, whoever is going to research use that sample for research. They know, let's say, this is at this point of time uh, when this was collected, but we don't really follow up with the patients unless, let's say, let's say the physician asks for, then that. Can you hear me? Sorry.
No, your voice was a bit breaking.
Sorry. Is it better now?
Yeah.
Uh, okay. So the okay, should I repeat my answer? So usually not. So I'll make it very brief. Usually not unless the physician asks for. Can you hear me?
Yeah.
Perfect.
Okay. Yes, 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 doctor. Doctor, we have more questions. Can we move to that?
Perfect.
Yeah. The question is, what decision will genomic program allow us to make in 5 years that we can't make today?
That's a very interesting question. Um, uh, uh, so Um, I think for me, the first thing is gonna be um, what are the, let's say, the the diseases that we've eradicated. Hopefully, we've eradicated within the next 5 years. So I'm hoping like the 5 years. That's a whole generation. So this will lead us to make sure that let's say, how did we do it, and then make another decision on how to eradicate other diseases as well. So that, let's say, for premarital genetic screening, let's say for cancer, hopefully we'll have novel discoveries that will enable us to have, let's say, more personalized diseases and drugs, sorry, for every patient. So we've all heard about the mRNA vaccine for cancer. So this is like a personalized vaccine for cancer. So if we are able to develop something like this within the next 5 years, then the decision for any oncologist is gonna be much, 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 much easier within the next 5 years. So as soon as they see a tumor, develop a vaccine for it, then treat that patient. So hopefully we'll be able to reach that stage within the next 5 years. But there are a lot of other questions, especially like economically, that we can make decisions on. But mostly focusing on patient's health, patient longevity, in the end. And I can tell you there's a lot of decisions that can be made. But these are some of the examples that I'm sure will be done within the next 5 years.
Doctor, moving on to the next question we have, what is the greatest risk of misalignment between science policy and public expectation?
Uh, the difference is the more, let's say, the most difficult part is awareness. And so science now with AI is moving very, 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 very fast. Whereas the public are not moving as fast as where science is going. And there's a lot of, let's say, misconception within, let's say, the public regarding let's say, like our job to make sure that we raise that awareness. So I think that's the most difficult part, because developing something like, let's say, pre-methylgenic screening, we struggled at the beginning. It's because the public was not aware of it and the importance of it. So that was one of the things that we faced, and we're facing the same thing with other programs such as newborn genetic screening as well. We need to make sure that the public is more aware of genomics and why are we doing these programs, and also they need to make sure that they're aware of, let's say, those, let's say, phishing companies that kind of like give you an ancestry result. But at the same time they make sure that they kind of like take your DNA as, let's say, I always say, take their DNA hostage, and in a way that they can use it in things that you wouldn't even know what they would use it for. So we need to educate the public as much as we can, making sure that they kind of like follow the same pace as the scientific discoveries.
Doctor, we are closing it. So, as we come to the end of this webinar, I would like to extend my sincere thanks to Dr. Mohammed for accepting our invitation, for delivering such an engaging, timely, and valuable presentation. Doctor, we truly appreciate the depth of your reflection and your practical perspective you have shared today. We are grateful for your rich insights you shared with us. I would also like to thank all the participants for joining us this evening for your active engagement throughout the session. Please do not forget to complete the evaluation form on the link shared in the chat, as this is required to obtain your CME certificates. We also invite to stay connected with the Institute of Public Health through our social media platforms and our upcoming webinar activities and our educational initiatives. Thank you once again for your time and participation. Wishing you all a pleasant evening. Goodbye. Assalamu alaikum.
Thank you very much, Lina.